Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we discuss ethical prioritization of patients for COVID-19 treatments when treatment supplies are limited. Joining us are Dr. Fernando Carnavali, Division Chief of General Internal Medicine at Mount Sinai Health, Dr. Rasika Karnik, Assistant Professor in the Department of Internal Medicine at the University of Chicago, Dr. Renslow Sherer, Professor of Medicine in the Section of Infectious Diseases and Global Health at the University of Chicago, and Dr. Joseph Torrisi, Clinical Pharmacy Specialist in Infectious Diseases at Grady Health System. For more information about Dr. Carnavali, Dr. Karnik, Dr. Sherer, and Dr. Torrisi, and for a link to the full online educational program, including downloadable slides, please visit the links in the show notes for this episode. Now, let's get started and hear what Dr. Carnavali, Dr. Karnik, Dr. Sherer, and Dr. Torrisi have to say about prioritizing patients for COVID-19 treatments when supplies are limited.
Treatment supply is limited, so this gets to this ethical prioritization. I mentioned the risk stratification. I don't know if the other ways that we approach this 3% of the population is critical, but it certainly means thinking carefully about how we should use these therapies is an important part of the process. I worry that we've been leaning too much towards restriction and not aggressive enough for anybody who qualifies for risk. You remember from the CDC list, it includes mental health disorder. It includes all cigarette smokers. There's some very broad categories. And so I actually worry that the field has been erring too much on the side of being cautious and not enabling to try to increase the number of people who are actually receiving Paxlovid, who have symptom reduction, but most importantly, stay out of the hospital. And I'm interested, panel, other thoughts on that, or shall we move on?
Just perhaps to add that, at least in my experience, what we're seeing too is like people declining treatment. All of a sudden, like the same wave of people requesting it at the very beginning. Now we have people that with more information concerned about receiving treatment. So just as a caveat into how we create research stratification, and I have a couple of instances where I was the right patient, but declined the treatment. So we're going to continue to see more of that. People are more aware of interactions, and I guess that we're going to hear more about that later too.
Yeah, I think I would just add too is the continued public health education efforts for patients and the population about treatments, vaccines, so that, when we do potentially liberalize it or whatnot, we have more therapies to add. It's not, again, an uphill battle to say, okay, here we go again of trying to educate people. So continued efforts.
I think something that comes up a lot is when supply is limited, to say the least, is, how do we stratify these people when you have a lot of patients all within the same tier come in, right? Like if you're at a transplant center, everyone's high risk. They're all tier 1, regardless of vaccination. Or I work at Grady, we have an AIDS service. They're all high risk usually because they have CD4 counts less than 200. And I think in those scenarios, sometimes you have to treat at a first come, first serve basis. And I think that comes to a patient, healthcare provider conversation at that point, sort of what you're talking about. Do they understand what the treatment is? Are they okay moving forward with it? And I agree. I think it's, hopefully we don't enter that scenario anytime soon. I think, over the past several months, it's been a lot easier to obtain access of these medications, which is nice. And it is widespread amongst the community, amongst pharmacies now and health systems, whether at ambulatory care clinics or inpatient sides. But I do think that is a thing where it comes into the point of, does the data support their use in this patient? How do we stratify that the best in these patients?
There was a question from a patient in my clinic last week. I'll ask Rasika, wanted to know, could we supply nirmatrelvir pills while they traveled internationally, just in the event that they received it? Have you received this, ever gotten this question, Rasika?
I have, and that's a tough one. It's that's a tough one for me to answer. I have received that question. Personally, I'm more willing to do it for patients that potentially are, transplanted or on some type of immunosuppressant. But the way I will stratify it is, if they're relatively healthy, I say, I don't think so. That's a tough one. And I think it's very personal. So anyone else?
That's a diplomatic answer. Yeah. I'm older, so I'll just say, yeah, I did it. And, yeah. But I met your criteria. So it was a person over age 65 who's otherwise immune compromised who traveled for work and was in Scandinavia and got COVID and took the medication. So that's a very tricky question. I don't mean to simplify it, But you can hear me leaning towards someone being at higher risk and anticipating that that is someone who's vulnerable to infection and wanting that person to be covered. It was our intention upon his return to return the medications, which is always also a tricky process. But so I'm siding on the side of being more aggressive with therapy.
Perhaps the only thing to take in consideration too is like their side effects, adverse events. So and all of a sudden that person that is traveling and will end up with the ritonavir side effects, adverse, and have diarrhea in the middle of the trip or nausea and vomiting. So there's a balance, not because they will not be able to reach out to you for the next prescription.
I'm sure Joe will talk to us about drug interactions as well, and that in the event of its use, many of you all in the audience are HIV clinicians, I'm sure, and you're not so daunted by the idea of co-administering ritonavir since we've done it for so long with boosted protease inhibitors. And we know that it's not the end of the world. There's some very important considerations that need to be taken into account. But in most cases, you can proceed safely. And there's a very good list in the NIH guidelines of acceptable treatments, alternative treatments. I encourage you to have that at the ready when you're taking care of patients, or to go to the Liverpool guide because they're terrific sources of information. But that is not a barrier that you can't overcome or manage. And actually, that was an issue with this patient that I treated. So I've made my confession.
Definitely.
Yeah. I've done it. And I listed out the interactions and whatnot with their medications, what to do. So I will freely admit it now.
Okay, good.
I think we'll get to some treatment options in a bit, but I always think it is nice when you're able to incorporate some of these different caveats with each of these medications into the electronic medical record, so physicians have an easier idea of, what's contraindicated. So it helps you sort of choose an agent that is best for the patient, whether it be side effect related or renal dysfunction or pregnancy, et cetera. So I think that also helps identify the right drug for that patient, is incorporating some sort of workflow into the electronic medical record when providing these or prescribing agents.
Thank you very much to Dr. Carnavali, Dr. Karnik, Dr. Sherer, and Dr. Torrisi, and thank you to our listeners for joining in. As a reminder, to view the full Clinical Care Options program on expert insights into optimal outpatient management of acute and long COVID-19, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.